wouldn't necessarily say that I'm a type A person or nurse, but I am an Aries, which means I don't like to be wrong, which means I have to study in order to get things right. And one of the things that I think is most important if you're going to the ICU or working in the ICU is to know how to advocate for your patient based on the intervention that they actually need. If I'm trying to decide between whether they need a bolus or a pressor, or a bolus and a inotrope, then I'm going to be looking at the hemodynamic monitoring. For preload, that's mostly going to be telling me if a bolus is going to be responsive. So I'm going to look at the CVP. And I'm going to look at the SVV, the stroke volume variation. If it's super high, then I know that they're going to be fluid responsive. If I'm thinking there's a contractility issue, then I'm going to be looking at the cardiac output, the cardiac index, or ejection fraction if you have it. If we're knowing that they are having a contractility issue, then we can give them dopamine or epi depending on what their status is. If I want to advocate for a pressor, I'm gonna look at their SVR. If their SVR is low, their systemic vascular resistance, then I know that they would greatly benefit from something like levo. So any of those things that I'm constantly monitoring, when the doctor comes in or when I speak to them and I can see a change in the status, I can always advocate for that patient based on what they actually need versus just like, oh, let's do a bolus first and then a pressor. If the bolus isn't gonna work, then the bolus isn't gonna work. If their CVP is super high, then there's no point in doing that. Let's just go with what it actually says the SVR is, which is low, so give the levo.